ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. If you've ever wondered what it actually takes to scale a specialty practice without burning out your people, this episode is for you. I sat down with one of my leadership role models, Charles Haberkern, who's the CEO of Rheumatology Specialty Center in the Philadelphia area. His practice has 22 providers across 6 offices, and they're still growing. We get into the business side of medicine, like how to hire the right leadership team, how much autonomy great leaders need, and what to do when deadlines get missed. We also talk about scaling without losing your footing, why a 4-day work week for medical staff can be better for patients and the team, and why consistent meetings matter more than most people think. Charles also breaks down the track to partnership, the value of open communication when nothing is off limits, and the biggest differences between hospitals and private clinics, especially since he's been a hospital executive too. Tune in for a candid, fireside-style conversation with one of my favorite healthcare executives. Charles Haberkern, welcome to Working Healthcare.
Thank you, Meredith. I'm so fortunate that I was on an ACR committee with your husband, which allowed me to meet you.
I am really looking forward to this interview because, and you don't know this, I don't think I've ever said this to you, and I need to. You are one of my role models.
I appreciate that.
And you are because you have such a kind, not even the kind nature about you, like you get crap done. People ask me, can I curse on this podcast? I said, well, yeah, but I don't curse. And my kids maybe sometimes listen to it, but I'm like, I'll keep it clean, especially for somebody I respect so much. But yeah, you get things done. You've taught me so much. You are involved in so many different aspects of healthcare. And I just admire you as a person. So thank you for doing that for me.
Well, I admire you. I mean, I look at everything that you've gotten done, your podcast and growing the group and allowing Mark to just be a physician is an amazing achievement.
It's funny you say that because we had a provider meeting yesterday morning. We do one every 2 months, and they voted to do one at 7:15 in the morning before they see patients. And that's probably up your alley because you were in the military. It is so not up my alley. And Krista, who is our executive director, and I would say something and share the business analytics or share concerns we're having. And Mark keeps chiming in. And Krista just sat back and chuckled a little bit. And afterwards I said, what was funny? She goes, he still doesn't know to stay in his lane. So last night I got home and I'm like, Mark, stay in your lane. And now when I get into the office, I'll say, I just interviewed Charles and he said, you're lucky that you have Meredith so you can just practice medicine. Stay in your lane.
Exactly.
Do you have guilt when you're out of the office? I know you work hard. I know you get stuff done. And that's what I said at the beginning. But this is where I get challenged. Even if I don't want to be in the office on Fridays, because Mark actually just recently, about a year and a half ago, took Fridays as an administrative day. And he's even doing some Zoom calls with our team as opposed to going in. And we're only 15 minutes from our practice. I continue to get emails. I continue to get phone calls. I continue to get text messages all of the time, even when right now, my mom just entered hospice last week, and it's been a really tough time for me, and I'm going up there to visit her and see her. She lives in the Pensacola area, and I'm still constantly flooded with phone calls, text messages, emails, and I get this sense of guilt. How do you handle that?
A good management team. I've allowed my management team, now I've promoted some people into positions of a lot greater responsibility. And I tell them, don't bring me problems. Tell me what's going on, offer me a solution. And then we'll discuss your solution. And if it's going to work out, I'll just say, just do it. And next time you don't have to ask me about something like this, just do it. And if the solution is maybe not going to work, I'll say, well, have you taken this into consideration or this? And if they say yes, okay, do it. And if it doesn't work, you know what the alternative solution is.
Charles, how do you hire the right people to do that? Because I really do go to you for leadership direction. You have a background being a CEO of a hospital. You were a sergeant in the U.S. Army. You have massive leadership background. How do you hire the right people to support you?
You don't always hire the right person. The person that shows up sometimes is not the person you interviewed. And if it doesn't work out, you have to admit your mistake and move on. Which means maybe 30 days after they started, you say, this isn't working out. Thank you very much. A lot of times you hire personality. Can I work with this person? And I have them talk to some of the other management team. Is this somebody you can work with? A lot of times they have the basic skills and they've just never been given the opportunity. They've never been allowed to make mistakes. And when I start somewhere as CEO or senior VP, I talk to my people and I tell them, I want you to make decisions. And what I want you to do is don't be afraid to make mistakes. Everybody makes mistakes. Now, the other part of that is if you habitually make mistakes, then we've got to talk about your thought process. Why are you always making mistakes?
What's the lead time to hire all of these new team members? I know it's different for a medical assistant. We just hired a radiology technologist who's starting next Monday. Thank goodness. But I'm telling you, that position was open for probably 5 months, and I'm not exaggerating. And it's because they're in the hospital right now. They're making a certain amount of money, which is much higher than what we can do in the private sector. And they're working per diem. So they don't understand they're not getting benefits, it seems like, because it's very expensive for us to provide benefits. But they're able to coordinate their schedule around their kids' schedule, and they're able to work when they want to work. And so they feel like they're losing some of that autonomy. So 5 months to hire an RT. What is the lead time for you to hire all of these positions?
As soon as I sign a contract, say with a new doctor, like if it's a new fellow, I've got 10 months lead time. But with MAs now, you almost have to start recruiting 10 months ahead of time. I mean, we're still 2 MAs short. So my director of nursing, at least 1, sometimes 2 days a week is rooming patients. We need 1 MA for every provider, and we just don't have that. So I think we have a medical assistant ad on Indeed just permanently. The interesting thing is with 16 providers and maybe 2 or 3 doctors being off on the same day, everybody else having to do the coverage was a nightmare. I mean, and during holidays, if 7 or 8 doctors are off, you can imagine the messages and the poor PAs are having to try to do coverage while they're doing, seeing their own patients. And it was a nightmare. So now everybody being off on Friday, everybody's working the same day, everybody's, doing their callbacks and things like that. So since the doctors were only working 4 days a week anyway, they're still seeing the same number of patients.
So what about patients who have more emergent care? I know you're not taking care of emergency visits, and especially in rheumatology, but what about the volume of calls that you must receive if you close your phones Thursday at the end of the day and you do not start listening to them until Monday morning?
A lot of the doctors, listen to their messages. They're taking care of their patients still. But if it's not emergent, we also 4 months before, maybe even 5 months before we made the switch, we had a huge education process for the patients and for our referral sources. Let them know we're going to be closed on Fridays. The thing is, a lot of practices, like the primary care, they stop seeing patients maybe 1:30, 2 o'clock, or maybe even stop seeing patients at noon on Fridays. And even some of our doctors, you'd see their schedules getting a little bit light on Friday afternoons, the ones that worked on Friday. I mean, there are quite a few practices that have gone to 4 days a week. I know 3 big rheumatology practices that have done it, and it's been very successful.
And then I think on my side, as the marketing person, right, the queen of advertising, oh, this is a great business opportunity. But I definitely know that I need to put in boundaries and set parameters, because I should not feel guilty if I am with my mom trying to take care of her during all of this chaos. I need to depend more on my leadership team and know and trust that they can do it. My challenge sometimes is I feel like I'm giving them the trust. I am saying, I want you to make the decision. This is your budget. I trust the decision that you will make. And sometimes deadlines aren't made, or they still come back to me and just want verification. And I had this example in a meeting yesterday. I said, you know what? Did I give you a budget? Yes. Did I tell you that you have the autonomy to use this budget to get the support that you need? Yes. Are you happy you have the budget and you can make this autonomous decision? Yes. Okay, go for it. What could I do better?
Well, when I give deadlines, I make sure I remind myself, a week, maybe 3 days, whatever, ahead of time to check on progress. Because if I've given somebody a deadline, it may be information that I have to give to my board. And the last thing I ever want to do is go to my board and say, well, I don't have the information that you requested. And I never blame it on my staff. They're not afraid to come in. Sometimes it's just to, anything going on I can help you with. And go, no, I've pretty much got everything straightened out. Today's the last day of the week for us. And it's like, no, actually, I think I can leave early today because, everything is done. How about you?
How do you get everything done with all of these interruptions?
I've given a lot of what the previous administrator, she was a person that wouldn't delegate anything. And I delegate a lot. And I explain, this is how I did it, but this is the result I need to get. I don't care if you do it my way. I just need this result, or I need this information, and I push it off.
What do you like about what you're doing better, or do you actually want to get back into the hospital world?
No. I was with 2 hospital systems, and I was a senior VP for physician services. I was with Ascension and I was with CHS. I had 170 doctors in Northern Virginia, Washington, D.C., and Maryland. And when we moved back from Annapolis, I told my wife, I'm not working with a hospital system. Everything before that was always with medical groups. There's always friction between a hospital and the employed groups, no matter what. When I was with CHS, my physicians CHS lost less money per physician, and I had over 300 doctors. We lost less money than any other group that CHS had, but that wasn't enough. So I like working directly with physicians and working towards either growing their group, fixing their group. There are all sorts of things, no matter what group you go to, there are things to fix, things to make better, or things to stop.
When you fixed all of these things, I love to do that too. I'm a fixer. When I fix it, I get bored. I'm like, oh, everything's running great. I'm out of here. So where do you then focus your attention and energy? Or are you moving around being Mr. Fixer?
No. I have fixed a lot of things, but fixing things now for this group means growing, expanding our footprint. We're up to 22 providers now. We'll be 6 offices on March 1st. Expanding our footprint and looking at ways to be more intimidating to the health plans. We have several contracts where we're getting more than Medicare. There's always something going on. We've been approached by smaller practices, and I've done two group analysis, and one of them just didn't fit. It wasn't going to work.
And why wouldn't it work? Is it because of the physician? Is it because of the skill set of the team or the location? Why did you choose it not to work?
Well, number one, he's got a big patient base, but he's got them all trained for self-injectables. And it's like, you need infusions to be more profitable. And there's no way. I talked, made the presentation. This is how much he makes. This is what we can do. And his practice style just didn't match ours. Now, I'm not saying that you infuse everybody, but infusion is a part of rheumatology.
Oh my goodness, it's our bread and butter. It's our biggest ancillary.
It's a profit center. And if you have a whole group of patients that are used to self-injectables and injections, and it's like you can't convert them. The other one, he was so underwater on bills. His office manager was stealing from him and wasn't paying the bills. He was behind in payroll taxes. You name it. And I just told him, call me when you get straightened out. It'd be an area we would love to expand to, but you sit there and look. There are other practices that we could certainly help. So it'd be immediate fix.
Well, that doctor who you said, and you said it very well, it was pretty much like, hey, I don't need to hear from you again, because if you told him to fix it, he's incapable of fixing it.
Yes. I've gone in and fixed practices. When I was early in my career, I worked for a publicly traded physician practice management company back when that was the vogue. Mm-hmm. And one of the primary care officers, or 7 doctors, Um, you know, 3 days before the deal was supposed to go through, I presented my analysis to Nashville and said the managing physician is taking money out of the retirement fund to pay his house bill. I mean, it was, the whole thing was just it. So we had a big meeting with all 30 doctors, and the CEO of it was a publicly traded company, just got up and said, this group over here, unless you hire Charles right now in this meeting to go in and fix your practice, you don't get to join the group. So he made them give me $1 and sign an agreement. And the next day I went in and fired like 15 people, took all the authority away from the managing physician, appointed a new managing physician. The highest paid primary care doctor in that group was making $80,000 a year. They were so inept. At the end of the first year, they're all making over 150. So I don't have a problem with fixing. I don't have time, Meredith, to fix a one doctor practice.
I agree. I totally agree.
It's just not efficient enough.
Right. Yeah. Especially somebody who is on the brink of retirement. So that's where I struggled. Last year, we brought in primary care, and he wasn't on the brink of retirement. He's my age. And I quickly realized, while somebody might say, hey, I'll change the way in which I practice, I'm able to adapt. I admire what you've been able to do with the Hirsh Center. I'd love to be a part of it. They don't.
Yeah, you have to look at how much time you have. When I was doing mergers with Ascension in Washington, D.C., it takes just as much time and effort to acquire a 2-doctor practice as it does a 6 or 8 doctor practice. And the 6 or 8 doctor practice is more used to groupthink.
Mm-hmm.
A 2-doctor practice, you have to fight with them over every decision. It's determining how much time you have, how much time you want to spend on a problem. And if it's not worth it, you have to be able to say no.
Yes. And this is my year of no, Charles. This is my year of no. But I told my leadership team that, and they laughed because they didn't take it as a negative. They took it as a positive, and they will remind me. So yesterday I was offered an opportunity, and they're like, isn't this your year of no? I said, but we have to get to the end goal. Where are we headed? And they're helping me stay in my lane so I don't take on all of these other opportunities.
Oh, exactly. During my management meeting, after I signed the agreement, the construction agreement, we were supposed to be open February 1st, but it took forever the lease. It was a huge real estate company. The lease was 84 pages long. And the other office I opened, 6 or 8 months ago, it was a 10-page lease. And it was constantly being changed. There are, a couple of groups that I think would be perfect fits.
Is this all physician funded, Charles?
Yes. Oh, we've built 2 offices. We've hired 6 physicians, and my partners have never taken a pay cut.
And how many partners are there?
As of January 1st, it went from 7 to 8.
So there are 8 of the 22 providers that you have. 8 are owners.
Right.
What do you look at when you're evaluating?
I've put together a calculation that shows what their compensation is, payroll taxes, malpractice, and a couple of other things thrown in there. And then I look at their service revenue, office visits, and things like that. And I take 90% of that to get the gross profit, because really, I don't look at MA cost or anything else. It's just 90% of the revenue takes care of supplies and things like that. on.
You don't look
and
at
then we
meds. Do you add meds into that?
Meds are on the other side. I look
Okay.
at infusion revenue and injections and things like that. And I take our profit margin. I calculate our profit margin on infusions every quarter. And so I look at the gross profit on service revenue, add it to the gross profit on infusion revenue, and compare it to the total cost of them being in the building. And it has to be positive, but I also throw in, because they get a very significant increase in pay, so I have to throw in partner payment. And they have to be contributing to the betterment of the group. You have to be able to support yourself, plus pay for the rent and the utilities and the staff and it's a very simple calculation, and I share it with them. And
do you give any type of productivity bonus for the first 2 years or the first 5 years?
It's not productivity based, because I'm in the first year, they're figuring out how to practice medicine.
Mm-hmm.
It's different in the real world. But we have so many new patients. We were turning away 50% of the new patients that were calling into our office. And even the ones that we would schedule, they're scheduled out 4 or 5 months. And they'd go ahead and accept that appointment and then go try to find an early one somewhere else. So now, depending on which doctor and which office they want to go to, we can get people in 2 weeks. I show everybody their numbers every month. Patients seen, new patients seen, established patients, RVUs, level of coding, all of that. And then, everybody gets their service revenue and total revenue and infusion revenue every month. There are a lot of things that information answers the questions before they ask it.
How often do you have a meeting with the doctors? Do you still allow the new people to meet with you and your team monthly, or do you separate that out?
We were having board meetings every month, but the partners, and actually the 2 partnership track, they get so much financial information now, monthly financials, different graphs. I think I send them 12 different graphs every month, in addition to financial statements. And I do a 1-page overview, so they don't have to go line item by line item. I give them a 1-page financial overview that they read, and they've got graphs, everything. So we've cut it to every other month on board meetings. And we have physician meetings, and we're starting all provider meetings. We're having, they're going to be annual meetings, PAs and physicians, in March. To see, we're kind of an open group. I get emails from the physicians, hey, what about this? And it may be something that I suggest, why don't we talk about it at the next board meeting? Or if it's something that I think is just maybe concerning 1 or 2 doctors, I'll take care of it right then. I set the agenda for the board meeting. I run the board meeting, and it's a smooth, seamless organization. So,
how many staff members do you have to support those 22 providers?
We have, I think, 110 employees, and I don't have any room. I need 2 billers. I honestly don't have any office space.
Honestly, billers don't even want to work in the office. You need to do that remotely. Like that's a whole remote thing anyway.
That opens a can of worms here. Everybody would want to. So it's just a blanket rule here. No working from home.
I like that. What about you? So let me ask you, because I could talk to you all day long because I love all of the information that I get from you and learning from you. Are you ever retiring? I know you've tried. You keep getting pulled back in.
I love working here. I mean, there are other opportunities, consulting, I actually was asked by one of the pharmaceutical companies, we need somebody on the operations side to go in and fix some of these practices that we know are in trouble. And if you fix them, we know they're going to buy more drugs from us.
Yeah.
So when I get done fixing practices, and I said, I see this as a very short-lived career with you. And I said, there is no guarantee like I'll be working for a year or two. And I said, no, thank you. And I appreciate working 4 days a week. I love what I'm doing. And it's just, there are other opportunities out there, but I can't see it being better than what I'm doing now.
If you decide or your wife says you can move down to Florida, you know who to reach out to because I need you. Like I need your type of help.
I know. It's just, honestly, Meredith, it's, my wife said, we talked about it. We were out of town a couple of weeks ago. We're on our way somewhere, and it was a couple-hour drive. And I said, well, retirement at some point. And she started laughing. She said, you're never going to retire. You always have to have something to do. And she said, even on Fridays, it's like, okay, well, she said, you have the whole day planned at 6:30 when you get up. And it's like, okay, well, I'm going to go down and feed the dogs. And then I'm going to go run errands. And then, and she said, I can't imagine you being home 5 days a week, extra. And
you would drive her crazy. So if you guys decide to get back to Florida,
I would be down there. I'd be down there tomorrow.
You know who to reach out to. So I want to wrap up and ask you, because you come from the hospital sector and you're in independent private practice right now. If you could create one change within our American healthcare system, what would that be?
I mean, I'd start small, fix prior auth.
Mm-hmm. That's not small. That's huge.
Yes. PBMs need to be reined in. You start stacking things on and the paperwork that your group and my group and everybody's group has to do just keeps layering on expenses, but revenue or reimbursement doesn't increase to cover the added costs. So, we're doing AI. We're looking at AI pre-certs. I already have virtual assistants doing our medical records. Several of our doctors are doing AI scribing, which is working out well. We're doing everything we can to do things in a more efficient and less expensive way. I know there's doctors out there that if everything was already authorized, they would churn the system, but they can be taken care of. Just quit adding costs and not paying us.
Charles Haberkern, thank you for joining me on Working Healthcare. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.